Again, the pyramid of evidence-based medicine is at the top, it is meta-analyses, systematic reviews, and then double-blinded randomized controlled trials. Then after that, you have things like retrospective and prospective cohort studies. Then you have case control studies. And then you have case series or even a case study. And then at the very bottom of the pyramid is expert opinion. But if a patient does not fit within, if they're not the studied population, for example, one of the studies we will mention is a study on a bunch of Scandinavian individuals, which have very different nature and nurture. They have different genetics and different lifestyle than your average American.
So now we move on to treatment and screening, what is recommended and what's not. And for the most part, these guidelines, there's probably, 40 recommendations. We don't have time to go through everything. So for the most part, I would like 90% of these are good recommendations that we tend to agree with. A couple that don't seem to make a lot of sense or would only apply to like a specific niche case. The first one, I think you had added this, screening for proteinuria, not recommended during the first 5 years of type 1 diabetes. And why would that be? Why would we say wait 5 years to see if this person's getting protein in their urine?
You're waiting until they have enough damage at the glomerular membrane to get protein through.
Waiting for damage.
Yeah. Kind of the same reason why you would want to wait until you have a heart attack to start a PCSK9 inhibitor.
Guidelines.
Yeah, the guidelines that are, again, best for the patient, as many newly graduated medical students and residents say. Not to hate on the guidelines. The guidelines are there for a reason. Again, the pyramid of evidence-based medicine is at the top. It is meta-analyses, systematic reviews, and then double-blinded randomized controlled trials. Then after that, you have things like retrospective and prospective cohort studies. Then you have case control studies. And then you have case series or even a case study. And then at the very bottom of the pyramid is expert opinion. But if a patient does not fit within, if they're not the studied population, for example, one of the studies we will mention is a study on a bunch of Scandinavian individuals, which have very different nature and nurture. They have different genetics and different lifestyle than your average American.
And this recommendation just seemed really, counterintuitive to myself. I don't see pediatrics in practice. The majority of type 1 diabetes is diagnosed during your pediatric stage before adulthood. But there is a percent of late onset type 1 diabetes that does occur. And that's what I tend to see in my practice because I'm only seeing adults. So it's a bit of selection bias there.
Yep.
But yeah, maybe if you have a 8-year-old who develops type 1 diabetes, you don't necessarily need to be screening for that proteinuria. But if you have a 30-year-old who develops type 1 diabetes, and we know we have interventions that can decrease that protein loss in the urine and preserve renal function, the answer to the question of what are you going to do with the test results is pretty apparent in that latter patient, in the 30-year-old.
Yeah. And I suppose we've already mentioned SGLT2s, which can help preserve renal function given the right case, but we could also mention ACEs and ARBs as being nephroprotective, even at very low doses, but they're of course not without side effects. And then also new medications like Corindia, which is a type of, I believe, aldosterone receptor antagonist, but it supposedly doesn't have the effects on the progesterone receptors and the androgen receptor that other medications in its class do, like spironolactone.
And then our next recommendation that, again, seems kind of counterintuitive is in asymptomatic patients, routine screening for coronary artery disease is not recommended as it does not improve outcomes as long as ASCVD risk factors are treated. And I suppose they're referring to things like calcium scores and CCTAs here. Those would be probably the most common screening methods. But if you're looking at the population, type 1 diabetics living 10 to 15 years less than the general population, so think 65 or 70 instead of 80, and the bulk of that being from cardiovascular disease, that seems like a very high yield population to screen. And I think I posted about the CCTA versus standard of care study recently on Instagram. People can check that out. But the bottom line is that CCTA screening leads to earlier treatment, earlier intervention, and better outcomes, meaning less people having heart attacks, less people dying from heart attacks. So, I mean, the odds of a false positive CCTA, something with a sensitivity like that, is exceedingly low. So I don't know, other than the cost, what the true harm of that kind of screening would be, but it's clear what the harm of not screening for coronary artery disease is in type 1 diabetes.
Yeah, for a type 1 diabetic, especially at the right age, perhaps not at age 13, but at the right age, a CCTA makes a lot of sense given that it is going to be a more significant risk factor than having an LDL of 131. And people know what we think about having elevated LDL, an elevated ApoB, and the need for basically screening and proving that you do not have clinically significant coronary artery disease. Otherwise, it's a bit of cholesterol roulette, I suppose. You don't want to play cholesterol roulette with your coronaries.
Yeah, I don't want to be a betting individual, especially when it comes to the fact that the average person is going to die from a heart attack. Mm-hmm. It's not something that you want to risk. And if it's something that you definitely want to be checking out and sort of fact checking yourself, if you do have a belief that your LDL is not pathogenic, then you obviously would want to know if you're wrong, hopefully.
Yeah. And like anything else, not to overemphasize this point, but maybe it does need overemphasized. You look at the risks and the benefits of each intervention. And with the CCTA, as you mentioned, the cost, potentially the contrast, a little bit of radiation. But if you get one every 5 years or every 2 years, it's not a huge amount of radiation, is going to far outweigh the detriment of not getting one in a very high risk individual, like type 1 diabetics inevitably will be at some day. So that's a good way to look at it. Some people would argue, why get a test that will not lead to a change in management? But we have CAD-RADS, again, that we've talked about, that leads to pretty clear evidence-based changes in management.
Yeah, and then also having the payers adopt that as this is sort of rolling out. People are getting initial CCTAs, and then if guidelines are saying, hey, we need to repeat this test at X interval, then it's going to be very difficult for payers to deny that. So I think it is rolling in the right direction.